end our talk mainly about breast cancer, just a few moments on breast cancer that is spread, what we call metastatic breast cancer. This is a CAT scan, and if you look at it, on the top is a CAT scan. It's like the lady in the circus. We've sawed her in half, and we've gone right through her liver. And this is her. She's lying on her back. Her feet are sticking out into the room, and her head is back into the screen. And she's lying on her back, and this is her spinal column. And you can see the liver has all these black spots, which are areas of cancer. This patient went on chemotherapy, and you can see these spots almost all went away. So why isn't this a cure? Well, the reason it's not a cure is although this chemo or hormonal therapy may last for a year or two, using different drugs, we can't kill every cancer cell, so the bad actors are going to grow back, and they're going to be resistant to the treatment that the patient is on. On the other hand, a lot of these patients, although we can't cure them, can have very meaningful long lives. And a lot of these patients are working and doing well and have good lives. We have a whole host of drugs to use, including chemotherapy, including different hormonal therapies. For certain patients, if they have like spread to a bone and they have pain, we use radiation. We've got a lot of tools. So this is just an example. Now, a lot of people say, Doc, isn't that liver cancer? So it's very, very important to understand doctors name cancers as to where they started. And patients tend to name the cancers as to where they end up. So a doctor seeing this in a patient who's had breast cancer, and we've put a needle in here and shown that these cancer cells look just like the ones in the breast, is going to say this is breast cancer that spread to the liver. And a patient's going to go home and say to their family, I have liver cancer now. In a way, both are right, but what's important, the doctor, a breast cancer in the liver is treated differently than a lung cancer in the liver frequently. And it really matters as far as how treatment is given in long-term prognosis. So the doctor's way allows us to pick the right treatments for the patient, and that's why we name them this way. It's always an area of confusion. So ending on some good news for the breast cancer portion, here's data from the United States and the United Kingdom, and you notice they have slightly higher mortality rates. But if you look at these curves in both the United States and the UK, they're similar to what I showed you earlier. They are going down since the 1990s, and they continue to go down by a few percent a year. So we are making great headway in improving outcomes for women with breast cancer. We've certainly got a ways to go. But this is very, very good, and why it's so important to get the appropriate treatment in the United States and in your community. Survivorship. About a third of Americans are going to get cancer, and right now there's at least 11 million Americans. There are many more we don't know from these data. The most common cancer survivors are patients with breast, prostate, and colon cancer because they can be cured. And so there's lots of people in the community with these cancers. 60% of the women and men who are surviving cancer are now 65 years and older, and about 14% of them are 20 years from diagnosis. So the importance of this is when you get the cancer, then many of you are going to do well. And you can't forget your other health as well. So getting cancer doesn't mean dealing with high cholesterol or hypertension or diabetes isn't important anymore. Our goal is to get everybody here, but to do that, we have to pay attention to your general health as well. In addition, depending on treatments, there are survivorship issues from the treatment of the cancer. Like, you may have gotten chemotherapy that causes nerve damage. And some of those types of problems, although they're not going to shorten your life, can really affect your quality of life. So all these things related to survivorship are further challenges, especially in older patients, but they're very important, and I'm showing this because a lot of us are interested in this. And many places and hospitals are building specific survivorship clinics to deal just with the issues of cancer patients who have survived their cancer but now have other issues in life either unrelated to cancer or related to their treatment of the cancer. Now I'm going to tell you a few things to end is how we deal with older people with cancer specifically. So the first issue, when you see an older person, they're all in your clinic with breast cancer, but is that really the problem in this patient's life? I give you an example of two people. On the right is Katharine Graham. She was editor of the Washington Post, Newsweek, an incredibly gifted woman, and she's 80 years old there, and she looks like she's ready to go. And on the left is her counterpart, an 80-year-old in a facility that's caring for her around the clock, who's got a little dementia, can't walk. They're both 80. Obviously, if these two people were in your office, you would think much differently about their potential management. There's no question about that, and we would all do that. So the questions we got to ask are, one of the goals of treatment: is this a potentially curative patient, or is it a stage 4 patient where it's going to be more controlling symptoms? How long is a patient going to live? If a patient comes in with breast cancer and they've on dialysis and they've had 3 heart attacks and other problems, a tiny breast cancer, certainly we're going to make some recommendations, but it's not really going to be what's affecting the patient's life. And then if we recommend treatment, what are the side effects? And although I won't dwell on it, what are the costs? And not just the financial costs, but the time costs. How are you going to get to the clinic if you're older? Does someone have to drive you? All these issues that relate to you and your family and your social support system. So one thing we're becoming very good at in oncology is to quickly but rather thoroughly go through your functional status, called a geriatric assessment. Now, we'd love to be able to send you to a great geriatrician if you're not feeling well, but they're getting very short in the United States, so we're learning how to do this ourselves. And here's an example of what we can do and what we do in our geriatric oncology clinic at UNC. Dr. Weiss, who's hosting it, has a study. He's doing this with many of his patients. But we look at your functional status. Basic stuff. Can you dress and wash yourself? Activities of daily living. They're key. You can't take care of yourself or live without help if you can't wash and bathe, etc. Instrumental activities of daily living are needed to essentially live alone. And these are paying your phone bill, doing your washing, picking up groceries. If you can't do this, you could be living by yourself in an apartment, but someone has to do it for you. Comorbidity is just how many other illnesses do you have in addition to your breast cancer that are consequential. Nutrition's important, and in older people, weight loss is scary because it may indicate malnutrition or side effects due to the cancer, which are very important. Cognition. Very important to directly assess memory in older people. You can be fooled, and we tend to do this with some very quick tests. And then what's key is what kind of support do older people have in the clinic? Do they have family that can bring them in, or are they by themselves in the community with very little support? And it's a monumental task to get them to the doctor. And then last, polypharmacy. We find in the United States we give people too many medicines. Frequently they see several doctors, and no doctor has a complete grasp of what they're taking. And we know that that really can interfere with people's lives, lead to immense costs, and be dangerous. So we measure the types of meds, make sure they're all appropriate, and frequently can we slim them down. So this is what we do. And I'm going to just give you an example of why this is important. So here is a little study that we did in 500 people to predict what we call grade 3 toxicity from chemotherapy. So grade 3s are side effects like mouth sores, nausea, vomiting, nerve damage, low blood counts that really impact people's lives. And so we wanted to see if we could, in older patients, predict these side effects, so we can make a better judgment on whether to treat them or whether to modify their doses, just do a better job in general. So what we did was we asked patients numerous questions, and we came up with key issues both clinically, like what type of cancer they had, what was their hemoglobin, their red blood cell count. But look at some of these questions here. 1 or more falls in 6 months, not being able to hear, can't walk a block, requiring help with medication, decreased social activity. These are questions frequently maybe your doctor has never asked you, but we've learned they're very important. And we obtained these in the geriatric assessment I just showed you. We had our statisticians give us a point system for all these things. So if you couldn't walk a block, you got 2 points off your scale for that. So how is this helpful? we've learned that we could take these points, and if you look here, this is the incidence, the number of grade 3 or more toxicities, serious toxicities. And these are the bar graphs. So if your points were between 0 and 5 points, pretty functional person, you had only about a 1 in 4 chance of getting any serious side effects. So a person like that, you could tell that patient, well, it's very likely you're not going to have any really great problems with the chemotherapy. On the other hand, if your points were higher, about half the patients are going to get side effects. And if you had a lot of points, like many things, look at this, almost everybody was going to get side effects. So if you came in and saw me and we were thinking about chemo, and I got this little assessment, which we're trying to do in many patients as possible, doesn't take very long, but unfortunately today we're all pressed for the time, then I might be able to look you in the eye and say, this chemotherapy may have too many side effects, or at least if we think it's a good idea to try it, we're going to start at a lower dose and work our way up, just so we don't have a terrible problem from the initial treatment. And so this is what we're trying to do with this information, is use it to best select treatments, in this case chemotherapy, but you can see how similar things could be used to select surgery or radiation or many other treatments related to patient care of cancer. So it's been a whirlwind tour, and I hope you've enjoyed this. Thank you for your attention.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our GRACE website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.